Thanks, Jeff. Thanks for having me in Innovasis. It's certainly mine and definitely my wife's favorite meeting of the year. So my disclosures, I'm part of a great center, a pretty major spine center with 5 other surgeons. I'm the junior partner. I have the good fortune of working with these guys. And I didn't really train in deformity. I was at Jefferson. We really didn't do many scoliosis cases, but really have learned a lot from my partners and have the good fortune of inheriting a lot of the cases they don't want to do. So you'll see some of those today. So the goals of spine surgery, we've talked about: we decompress, we stabilize when unstable. What most important we're talking about today is to preserve and restore alignment. I think this starts with every case, a simple degenerative case, and I think every fusion case that I do, I'm getting 36-inch cassette films to really look at the overall balance, and I think that's very important. Jean Dubuisset, this has been shown before, looking at that cone of balance, really the stable zone. We exert a lot of energy when we're out of that stable zone. It's been shown consistently. It's also been shown that the sagittal plane is really the most important when we look at disability, and really really deviating from that stable zone results in energy expenditure. So when we look at some of the clinical studies, when we shift our sagittal profile forward, there's an obvious increase in disability from multiple clinical studies. This is very important, I think, to be a part of the solution, really not part of the problem. A lot of what we do is correcting these iatrogenic deformities, really created from fusions that really didn't take these basic parameters into account. So really taking into account these global sagittal parameters as well as the regional balance will lead, if you don't, will lead to a poor outcome. So sagittal surgery corrects the neural impingement and instability, but causes poor sagittal coronal balance, certainly results in a bad result. So with an attempted correction of sagittal imbalance, 40%, it's been shown 47% of patients will still have residual deformities. And the unfortunate part is correcting these deformities really have a high complication rate. So again, treatment of these iatrogenic flat back deformities should begin by prevention. We've seen this slide before, just looking at our basic parameters and keeping this in mind with every case that we do. So when we look at looking at candidates for these deformity surgeries, we look at patients who are aligned, who have their pelvic incidence lumbar lordosis matched well, and then you have the patient who has a little bit of an imbalance, but they're able to compensate through pelvic retroversion, through knee flexion, thoracic hypokyphosis. And when then they start to decompensate is when we start to see significant disability, and a lot of times these are the patients that come into our offices. So again, the mechanisms of compensation, pelvic retroversion, they flex their knees, they hypokyphose the thoracic spine, and often hyperextend their cervical spine. And certainly as we age with hip disease, and the aging process contributes to this decompensation and ultimately results in increased disability. This is just important. We certainly use the 36-inch cassettes, but we have to keep in mind what happens when you add knee flexion. Can give us kind of a false impression of their global sagittal parameters. So considerations in any deformity case. So we talked about before, age comorbidities are of principal importance. We're looking at bone quality. Oftentimes, we really have to factor in the magnitude of correction that we're planning based on these, based on age, based on how significant the deformity is. Available disc spaces, I think this is a very important principle that typically in the past when we only had Smith-Petersen osteotomies and our big osteotomies, now we have these hyperlordotic prostheses. We have the lateral approach, and we have these hyperlordotic A-lifts that really help dramatically improve sagittal alignments. And then looking at supine radiographs, I think it's very important to look at any passive correction that you could achieve. Certainly looking at any opportunity to correct at a lower lumbar level. Patients who, if we're looking at a fixed flat back deformity and we have available levels in the upper lumbar spine. Oftentimes it seems enticing to try to make a correction at those levels, but that unsound lumbar lordosis and the ability to correct at the low lumbar levels creates a better outcome. So looking at the surgical options from the posterior approach, I'm not going to talk much about the TLIF or PLIF. I know some have experience. I'm a little scared trying to break the anterior longitudinal ligament from a posterior approach. I know there are some that are able to get pretty profound corrections, and that's not me. Talk about the old school kind of osteotomies. Our Smith-Petersen osteotomy gives us about 5 to 15 degrees per level. A PSO get upwards of 40 degrees per level. Certainly for the larger correction, we're looking at a wide vertebral column resection. So again, our osteotomy selection, oftentimes a surgeon map does help us in these the planning our corrections. Dynamic radiographs of flexion extension, looking at supine bolster radiographs to see what type of correction you'd be surprised what you can get by just putting a patient flat on the x-ray table. Intraoperative positioning, as Dr. Decky was pointing out, using whatever table you utilize, you have to take into account some of the positioning and what will actually happen on the table in the prone position. So certainly, generally speaking, overcorrection is superior to under. Now that doesn't always come into play when we're dealing with older patients with very large deformities who may, undercorrection might be the better option. So again, looking at our alignment objectives, the Smith-Petersen osteotomy, or essentially resecting the posterior elements. The goal is to hinge on that posterior vertebral body and disc and to distract the anterior column. It requires a wide foraminotomy and lateral resection. This is a case that is not my case. Multi-level spondylosis, had a previous single-level fusion. Multi-level Smith-Petersen osteotomy creates a good improvement in alignment. The PSO for your larger fixed deformities really require the resection, total resection of the posterior elements, and with resection of the partial posterior elements above and below. Good for stiffer fixed deformities. This is a patient of mine that had two previous surgeries, had significant mismatch, and essentially we did an L3 PSO and revision T10 of the pelvis, got a good correction. I wanted to point out the technique that we utilize is this short segment fixation. It allows us to get a good correction and hold that correction. Trying to contour a rod into that focal correction is very difficult, and oftentimes you lose it. We actually have a segmental distractor where we can actually place on the pedicle screws and compress and really hold our reduction while we put our short segment fixation. The other benefit of this is that we can, when we're contouring our long rod, it doesn't have that focal bend, so some of the biomechanical properties aren't lost. Another PSO, this was done, a patient we attempted, it was essentially 2 surgeries. First one was a short segment, a hyperlordotic prosthesis was attempted. This was a younger patient, unfortunately continued to have a significant global malalignment. So he was a younger guy, benefited from a revision with a PSO. I also sometimes utilize the satellite rod, so it was really 6 rods across. Oftentimes above and below like to have an inner body. In this patient, it was really questioned whether or not we wanted to do that. Having the 6 rods was an alternative option. That's his correction there. The VCR, the vertebral column resection, this was a patient, oftentimes at our centers, really for all these big cases, and working closely with one of our other surgeons, John White, this case I did with him. This patient had, I think, 7 or 8 surgeries. Unfortunately, she developed a significant cervical thoracic kyphosis. We were following her, really didn't have optimal bone quality. We put her on for Forteo. The problem was she was tenting her skin and started to have superficial skin changes. We were concerned about it all falling apart and opening up. So we took her after about 6 months of Forteo. This just shows the bolstered radiographs. She was really inflexible. Looking at her clinically, and we did vertebral column resection, and there's just some intraoperative radiographs. And that's the distractor that we have from another company, but it actually helps really hold that reduction. We can actually image and really see real time if you're doing. It's also very helpful if we're doing an asymmetric correction of a coronal deformity, but we're really able to hold that correction while we run our short segment fixation, and it's just been really changed the way we were able to do these surgeries.
Can you theorize as to why she developed that deformity?
I think it was more of a thoracic kyphosis and a progressive. I think she was fixed flat and had a cervical thoracic deformity, and then she progressed. It was more of a thoracic kyphosis. It was progressive, so over time we saw that she just was progressively getting worse. Partially was because I think she was fixed flat in her cervical, at her cervical thoracic junction. Her initial surgeries were from C2 to T2.
So initial surgery should have been cervical thoracic.
She initial surgeries were anterior, and then she had a revision anterior posterior, and then she had. Her last surgery was essentially to augment what was done anteriorly all the way down to T2, but her thoracic kyphosis, I mean, in retrospect, yeah, it should have been more of something similar to this a long time ago before she started to, she was a young patient. We had to optimize her clinically, and she's actually done very well. So this is an intraoperative radiograph showing the closure of our osteotomy site. And then so she is, that's her clinically now. And like was stated before, I mean, these patients are chronic patients. I mean, this patient was, basically has been a life or death situation for her. She's done well. I mean, she's still taking pain medications, but overall, I mean, she's happy. So complications are a big issue, and we're looking at the ability to correct at a segmental, I'll talk about in a second, these hypolordotic prostheses. It does cut down on some of these complications. It's very common to see these complications, long hospital stays. So as we go from the simple Smith-Petersen osteotomy all the way to the VCR, we see those complications increase dramatically. So ALIFs, we're getting a better restoration of alignment. We're getting height restoration, spondylolisthesis correction, complication reduction. We're looking at correction at those lower segments from L4 to S1. It really gives us a more fluid and improved correction. We look at the majority of our lordosis comes at those lower levels. So if we have the option to correct there, we do. So this is an example of a short segment correction. This guy had a really two-level disease, a spondylolisthesis of 4-5. Looking at the pelvic incisive lordosis mismatch, it was 20. We typically would just consider fusing at alignment, but taking in and having these hypolordotic prostheses, we're really able to dial in the specific correction. This is a patient with just actually Jeff Deckey's patient that I helped him with. This is typically what my patient looks like, though. He really had two problems with cervical thoracic kyphosis and lumbar kyphosis. Very ankylosed, a significant positive sagittal deformity. So it was a really two-part procedure. We first addressed his cervical spine. We did, I think it was a C7 PSO on him. Came back, this is really to show the effects of multi-level anterior correction. So a multi-level segmental interbody grafts with a hypolordotic prosthesis, and then looking at his correction. And then Dr. Deckey was tired after that. So this is another example. What was that?
That was during the surgery, wasn't it?
That was while I was closing, I think. So this is a patient who had 2 years prior. It was multi-level X-lift and then a T-lift. Really wasn't corrected adequately. Had a pseudo at 5-1. You can see the T-lift. This is a bigger guy. He's not totally unhealthy, but I'm looking for creative options in him. Actually did a posterior removal of all his hardware, an osteotomy just the resection of all the facet, and Smith-Petersen type osteotomy at L5S1. Actually did get a massive dural tear in that situation, but let me go back. But put in a hyperlordotic prosthesis and then came back and dropped the rods. And so, I mean, he's done really, really well. But as opposed to doing a major 3-column osteotomy and still having to address the pseudo at 5-1, this was a creative option that we have because of that hyperlordotic option. Sorry, I'll move quick here. The laterals are great. We've heard about it. I don't have to talk too much about the benefits here. Some of the initial studies just specifically for scoliosis. The hyperlordotic prosthesis, you really have to have some training. I've learned, fortunately, from my colleagues how to do this. You really have to pay attention to your MRI scan, in my opinion. We actually approach from the right side, so we have our vein right in view, and I really look anterior to the vertebral body to see if there's that nice strip of fat. It actually gives me confidence in bigger patients. You're able to slide your retractor anteriorly. I sharply remove as much as I can see. Usually there's a contralateral anterior piece of the ALL that you can usually break with your trials. You have to be careful with that, though. Once you release it, it really is easy to get good correction. So the key for any of these hyperlordotic prosthesis, I think Jeff alluded to before, is we have to really be sure we decompress posteriorly the neural frame and make sure that your nerves have room. This is just a cadaver looking at the ALL. That's kind of our view there, and our view intraoperatively. This patient was a younger patient who had a burst fracture that was treated with iliac crest bone graft and a short segment, focally kyphotic, back pain. She had neurologic issues. She was on significant narcotics, so she had thoracic lordosis, significant kyphosis. She's the screws were going to the disc space, significant adjacent disease at 3-4. So, I mean, the options to do a large PSO, anterior, posterior. Do you go long on her if she's still a younger patient? Chose the option of doing a hyperlordotic cage at the level below and a short segment fixation just one day in the hospital. So, I mean, it's not a perfect case, but she's off narcotics, and certainly she'll probably need something in the future. And this is actually Jeff's patient as well, 55-year-old male, had previous in situ L4S1 fusion and a lamina above. This is really important looking at the supine radiographs. You see how they open up. A nice disc, nice vacuum sign there to take advantage of. So a hyperlordotic at the level above that gives us a great 34 degrees of kyphosis to 36 degrees of lordosis. That's what it looks like on the CT scan. So really looking, again, at the algorithm, flexibility, bone quality, available disc spaces, patient factors, aging comorbidities have to take into account. I bring this up again, looking at patients who are older, have very large sagittal plane deformities, may not be great bone quality. There's a slew of patients in their 70s and 80s who come to us who are significantly disabled. This is just an example. I've followed her for a number of years, treated with Forteo, and she just got to a point where she started to use a wheelchair, really wanted to do something about it. I mean, in a younger patient, I would definitely consider something more corrective at the lower levels. It's a little bit of a controversial topic, but get a correction with a hyperlordotic lateral. Did carry her all the way up because of that risk of PJK. She had treated for a year on Forteo, and she's done actually quite well. Another patient, obese, diabetic, younger patient, again, looking at, is this someone we want to overcorrect? It was something considering the risk, and he already has a spinal cord stimulator there. So the options for him, also taking into account what can happen for potential for PJK. I think it's this was a hyperlordotic expandable cage option. Doing a large PSO in him, not necessarily a great option. Certainly not a perfect correction after a year. He is falling forward, but I think it has to do a lot with his habitus as well. So sagittal balance, really the dominant predictor in deformity. Correction requires attention to all these parameters. Osteotomies are still very important tools. We do have these new techniques that are really revolutionizing how we do this, lessening the complication rate, reducing hospital stay. And preoperative planning is of principal importance. Bone quality parameters, do we undercorrect? Can we use one of these novel, less invasive options? Thank you.